All right.
Okay.
Looks
So,
great.
yep. Shall we start off?
Yes, ma'am.
Okay. So, thanks again for the invitation to talk to you about the role of electrodiagnosis and ultrasound in traumatic nerve injury and the prognosis. As you said, my name is Nens van Alfen. I'm an associate professor of neurology in the Radboud University Medical Center in Nijmegen, the Netherlands, which is sort of over there. And here are my disclosures, adding that anything I earn goes to my employer. So let me take you on a tour. We're going to tour this prognostic universe when we talk about nerve trauma. And there's a lot of things out there that we can see and visit maybe. And you see there are planets of different sizes. And I think we're going to focus on the large ones first. So nerve continuity is a big issue here. And injury mechanism, age are also very important. And then we're going to take these small vessels and travel a bit to ultrasound and EMG. And in the end, I hope you get a good, nice view of this universe when we end the talk. So basically, if you look at the literature for nerve trauma, and it's a little bit like this. This is a parable of blind scientists examining an elephant. And basically, well, in our case, it would look like this. The literature is there, but it's always focused on one of these aspects of nerve trauma and prognosis. So what is quite difficult here is to get that big picture. So that's sort of, I've aimed of trying to sketch you the whole picture, and that's kind of difficult because it's a very broad topic. And then in the end, we're going to zoom in a little bit, especially on the role of nerve imaging, which is relatively new. So, but let's start off with some general prognostic considerations. So everyone is, I think, is familiar with this grading system. Sidney Sunderland devised it. And he graded nerve ultrasound from grade 1 to grade 5, where 1 is just block, so something your body can repair within several hours to several weeks. And grade 5 is a complete transection of the nerve without any chance of spontaneous recovery. I must add that over the years, I think the group of Susan McKinnon also added a grade 6, which is basically saying that a nerve along its length can have different grades at different levels. So that's a mixed grade. If you want. But we know a couple of things for sure. And one of them is that if there is any chance of spontaneous recovery, it's always better than what we can do surgically. So if you have an intact nerve, like the one on the left here, the prognosis is inherently better than the one on the right, where it's completely transected. What we also know is that the prognosis is worse if you have a disturbed fascicular architecture. So if there's internal damage to the connective tissue structures and these nerve fibers cannot regrow in their own tube, then you get this whorled appearance. Some axons actually escape from the neuroma sometimes. And this is also a factor that indicates a worse prognosis. And we know that axons do regrow. They regrow at about 1 millimeter per day. But if you're young, it's a little bit faster. And if you have a proximal lesion, it's probably also a little bit faster, but then you have more length to cover. So that is another factor that is important. And that is because there is a reinnervation window of opportunity. So the axon tubes and the muscle fibers, they facilitate the regrowth and ingrowth of new nerve fibers for about a year, year and a half. But after that, the molecular signaling sort of stops. And if the nerve growth cone isn't there yet, it's not going to happen. So you have about a year and a half. And this is a problem in very proximal lesions, obviously. And the good news in our body is that axons can help each other. So this is on the left, you see one axon innervating one motor unit, so one end plate terminal in this picture. But if there is damage to his colleagues, then he can take over, this axon can take over up to, I don't know, 400 or 4 times his own size. So you get 4 end plates attached to one axon. And this is called collateral sprouting or collateral reinnervation. And this will sort of get back the muscle, or get the reinnervation back to all the muscle with about 1/4 of the axons. But there's a price tag to this, because if you need to collaterally reinnervate a muscle and you need to do the work afterwards with fewer axons, and these get tired during a maintained posture or action, then there is no one to turn to. Normally they're like this road cycling team, right? When they go against the wind, then one is in the front and he catches all the wind, does the work. And then if he's fatigued, he can drop back and then someone else will take over. And in case of motor units, if you try and perform a sustained contraction, it's the same. So when they are fatigued, they will stop and the other half of the muscle will take over. But if the other half of the axons is no longer there, then there's no one to look to when one half gets fatigued. And this is at large, I think, the most hindersome result of our body reinnervating muscles that patients will tell you, because their day is still 24 hours long and their work time hasn't gotten any shorter either, and they just can't keep up. And that's the decreased endurance is a very important factor in prognosis. So here's a case of acute trauma.
Oh.
So just a small video to get us across to the new part of this topic. So what do you need to know in the acute phase of trauma? Well, obviously, and this poor fellow is sort of illustrating that, it starts with A, B, and C. And in this case, I'm not sure if we would get any further, but then we move on to the D. And if we go to the neurological side of injury, we need to be precise. I don't know about you, but in my country, my fellow neurologists usually aren't that precise when it comes to injury mechanisms. So they will ask the patient, okay, what happened? Patient will say, well, I fell or I stumbled, and that's it. But you want to know, how did you fall? What part of the body was hit? What mechanical impact was there? In what direction? Because you want to sort of, in your mind, predict the mechanical impact on the internal structures of a limb or the chest wall, and then predict nerve injury. The other thing you want to know in this acute phase is whether it's open or closed. So if there's any wound and you can see visibly transected other structures like tendons or arteries, you know there's been enough force in there to also disrupt the nerve. And if it's an open injury, you actually need to inspect directly. And if it's damaged, you need to repair it, obviously. So something else you want to do in the acute phase is, of course, assess the extent of motor and sensory function loss. So how weak is it? Where is it? What nerve territory is involved? And then you sort of chart the whole patient and you can start your therapeutic approach and guidance from there. Now, you don't even need to be a neurologist to do this in the acute phase. So we've had this cooperation with our local anesthesiology teams in 2 hospitals and our surgeons, that if any perioperative injury occurs, they will call us, they will explain, and we say, just send over the patient and fill out this small chart for us. Just mark the spot with an X. And that actually works much better than just having them free flow fill out an EDx referral form, for example. We'll just look up the nerve and we'll measure there. And of course, we do take our own history when we see the patient. But, well, does a clinical exam help you in this acute phase? Yeah, to determine the extent of the lesion, so what nerve territories are involved, obviously, yes. But if you want to talk about lesion severity and then subsequent prognosis, it doesn't at all, because you can have a complete paralysis and it can be just block. So it can resolve within a couple of hours or weeks without any residual deficit. But it could also be a complete transection of the nerve that will never recover by itself. Something else that's rather inconvenient is that the MRC grading system that we use for muscle strength is really very non-linear. It's not a good test given the current standards of methodology. So of course, 0 is a paralysis and 5 is normal, but grade 4 is about 90% of your strength range in newtons. So it's not really saying anything at all if you grade a muscle grade 4. Now, let's go back again to the main determinant of PNS injury prognosis in that acute phase. And I think we sort of circled around this already, but it's continuity. So if it's cut, it needs to be repaired. And if you don't know if it's cut, you need to visualize it. I think that's the main point of this talk is this. Now, how can you visualize a nerve? Well, again, if it's an open wound, you need direct surgical inspection. And sometimes in our setting in the Netherlands, this means that you will have to actively coach the people in the ER to not just suture the tendon together, but also inspect the nerve and have a neuro or plastic surgeon operate those if needed. But if it's a closed wound, things get a little murkier. So, and in this case, I think the new part of this story is that you can use nerve imaging to assess continuity in that hyperacute phase. And there's two examples on this slide. So in the lower left, there's an ultrasound image of an ulnar nerve actually in the forearm that's been injured by a bone shard after a fracture. And you can see the transected area there. On the right is a beautiful MR neurography image where you see a brachial plexus transection. I'm not sure about acute phase or not for this one, but these are very good techniques to look at continuity, which is very important for prognosis. Now, which one should you use? Ultrasound, MRI, or both? Well, they both have their pros and cons, and I'm not saying that either of them is better. You just need to be aware of what you can use them for. So I try to make it a little easier for you by coloring these points. And so ultrasound has a few advantages in the sense that the resolution, the lateral resolution is very high in the superficial regions. So any distal limb nerve, for example, you can visualize with much higher lateral resolution than an MRI could at this point, even 7 Tesla MRI, for example. It's also easy to see the nerve along its whole length, because if you can access the limb, you can just scan it all the way from plexus to fingertips if you want. And it's bedside, so you can take the machine or the apparatus to the patient, to the ICU, to the ER, wherever you need to go. And usually you don't need any extra sedation or analgesia. Obviously, if the limb is broken or damaged and is painful touching it, well, then you need to assure that the patient has sufficient analgesia to undergo the exam. But it's not like they're claustrophobic or anything, so usually they do fine. But a main drawback of ultrasound, obviously, is that some regions are inaccessible. So you cannot see through bone and you cannot see through air, meaning that you, for example, can't see the intraspinal nerve roots in brachial plexus injury, or you can't see a small region behind the clavicle, directly behind the clavicle, but you can also not see the deep regions of the lumbosacral plexus, for example. And if there's a plaster cast around the patient, or there's a bone screw or a plate or anything over the nerve, then it's also inaccessible. And that's, the good thing about MRI is that you have a really large field of view. You can see the nerves in their anatomical context, which is great for surgical planning, and you can access these deep regions. But again, spatial resolution is less, and you do need specific scanning protocols and also coils, which are not always readily available in every center. And to be honest, both of these techniques are actually operator dependent, and they both require expertise in acquiring the images, but also in evaluating them. Now, how do they compare? Well, this is a study from, I think, 2013, performed by a group in the USA. And they looked in 53 patients with nerve injury who had both ultrasound and MRI. And this is the summary of it. So ultrasound is more sensitive, which is a little bit what we expected based on the lateral resolution difference. And it's equally specific. So, but it's easier to identify multiple sites with ultrasound, obviously, because you can just scan the whole nerve along its length. So this is a head-to-head direct comparison of them. So,
although I have to comment that WashU never put much into doing good MRI neurography. They do pretty typical sequences. But
okay, well that's a fair point, because the better your neuroradiologist gets, the smaller the difference, obviously.
Yeah, but Zaidman does a very nice job with the ultrasound.
Yeah. So it really depends, I think, on your setting and what you have access to. And to be honest, again, here in the Netherlands, we have a lot of radiologists, but none of them I have found that is really interested in MR neurography. So we have to rely on something else. But I know of some colleagues in your country, in upstate New York, who have beautiful MR neurography images and can find anything. So, so maybe based on the average practice in my country, if you again doubt continuity, then we would say try to perform imaging, and in our case nerve ultrasound, as soon as you can, just day 1 or day 2, whatever. And if you suspect a deep or intraspinal lesion, so the proximal nerve rootlets, for example, then also do the MRI for that part.
Yeah.
In this case, you just cover the whole nerve and you won't miss it.
Absolutely.
So this is just, this is a free access paper that we published with a German colleague. We have the two centers that do a lot of this traumatic nerve injury. And it's just a really practical overview. So if you sort of want to get up to speed on this topic, this is recommended. So let's go through the literature a little bit. So we talked about the MRI and the difference in sensitivity, specificity, given the fact that a regular MRI was used. There's also people who looked at whether ultrasound actually changes anything in your diagnosis or your therapeutic approach. And well, in that series, I think that was from Italy, Rome, it did in over half of these cases. So you do seem to add something by adding form to function. And it's been found most useful when there's really severe axonal damage. So if you have no EMG signal, then you know it's damaged, but you already knew that. And then ultrasound provides some extra. And there's an older study that looked at brachial plexopathy or injuries. And they found that for extraforaminal lesions, ultrasound also had this higher resolution, if you are an experienced operator, that is. So there's been colleagues who said outright that ultrasound should be considered in the standard of care for all cases of peripheral nerve trauma. And I think just based on the practicality of it, I would tend to agree.
Yeah.
This is just a small case example. So this is a 25-year-old male that we saw a couple of weeks ago who underwent a proximal tibial derotation osteotomy before a congenital exorotation deformation. And post-operatively, he had a fibular nerve palsy. Apparently, this was somewhat expected by the surgeon. So at first, they didn't do much. But then he also developed increasing pain and turned out to be an anterior compartment syndrome. And he needed emergency fasciotomy. So that was performed 2 days later. And then he was transferred to we are a tertiary clinic for this, both to look at the skin grafts that were needed for the fasciotomy wounds, but also to look at that nerve malfunction because nothing had improved after fasciotomy. Here's a small video of his ultrasound results. So I'll show you and maybe I'll comment a few lines. So here's the fibular head and the common fibular nerve. There's lots of edema in the connective tissue structures here. And we're going to go from proximal around the fibular neck. The nerve is still lying on the bone. To the deeper regions of the mid-anticus compartment. And you see a nerve swelling here all of a sudden. So it becomes hypoechogenic, dark, and then we go back up a little bit to see what's happening over there. So this was the nerve lesion. This is the longitudinal image of it lying on top of that bone with this swelling in the middle that is not really continuous. We can't really see what's going on in that dark part. And this turned out to be an intraneural hematoma, and it had the appearance of a crush lesion, crush injury. So we sort of guesstimated that this might be an effect of a combination of, for example, the Hohmann retractor that was apparently used to protect the soft tissues. I'm not sure if it did that. And then also the compartment syndrome pressure that was building up afterwards. So this is an unfortunate guy who, well, he's still, it's not really recovering now, and he had some complications as well. But the main teaching point from this ultrasound, adding to the clinical exam, was that the lesion was much more distal than the surgeon expected. So because of the nature of the surgery, they expected it at the fibular head level, and it was about 10 centimeters more distal than that. And even while there was a pretty severe palsy, well, this nerve is intact. So at that point, you're not going to touch it anymore, and you're going to see how it develops. And after 3 to 4 months, we will reassess and see if any further nerve treatment is needed. So this is just a small recap. What's the advantage of ultrasound in nerve trauma? Well, obviously it's painless. You don't need any sedation. It's no radiating exposure. There is no delay. So as soon as the patient is there and you are there, you can scan and you can localize exactly. It's also important to sort of try and tell the patient how long you can expect it to take to reinnervate. You can assess the continuity, obviously, and it complements the EMG, or rather, in this case, in this early stage, it's vice versa. And then the MRI, what we talked about already. But then again, I'm a clinical neurophysiologist by training. So what about electrodiagnosis? Well, obviously it's a standard for years, and there's several good things about it. If you, after 2 weeks, so we must start with that, but if you find a decreased recruitment but no denervation on needle EMG, then you probably have mainly conduction block and most likely a good recovery. And the same goes for sensory responses. If they're still present, it's a good sign. And if there are motor units present, those axons are continuous. So you know at least part of the nerve is intact. Another part could not be, but sometimes you're not sure about that. If you have CMAP amplitudes that are more than 30% of the lower limit of normal for that muscle, then that also indicates a favorable prognosis because you have enough axons left to collaterally reinnervate, for example. And if you have less than 10% of your CMAP amplitude left, it indicates a worse prognosis. And this has been particularly highlighted for facial nerve trauma. And then needle EMG will predict reinnervation 2 months before the clinical effect starts to become clear. So that can also help raise confidence in you and your patient that actually something is actually recovering. So, but there are some drawbacks here because, well, the main one is actually that first 2 weeks after injury, because it takes somewhere between 8 to 14 days before Wallerian degeneration has sort of dissolved the end plate zone, and only then denervation will become evident in the muscle when you put a needle in. So the first 2 weeks, you're not really sure. And if you cannot recruit any motor unit, you don't know for sure if it's a completely transected nerve or just block again. And so also the amount of denervation that you see when you stick the needle in is not related to the amount of axonal loss. So it doesn't predict anything. Nerve conduction velocities are not that informative and they are not related to outcome. And if you had time, like 3 to 4 months, and collateral reinnervation has taken place, then you can have a normal CMAP amplitude with as little as 25% of the original axon content. So CMAP amplitudes are not really a good measure of axon content after these months. Like anything, it's also operator dependent, and usually you can't study all muscles. We do, I don't know, 12 to 15 would be a very large number to study in one patient in one session, but you don't do 50 as in a whole upper limb, which also means there's a chance of a sample error. If you have a fascicular lesion, you can go wrong. And then not all patients can undergo this procedure. And I think EDx is usually best in the later stages of trauma when you want to know about reinnervation. So, but imaging can also help your electrodiagnosis. So if you really want to go to a particular muscle, like here the APB, why don't stick the needle in and have a look? Because now we're sure that we are there where we anatomically want to be. And there is a lot of literature on needle hitting the target with a needle on botulinum toxin injections, for example, where the hit rates are abominable. So like in the lower leg, it might be 10% hit rate for tibialis posterior or something. So imaging can help you there. Also, if you have an ultrasound machine that allows a high frame rate, like this 72 frames per second, and you turn the smoothing software off, you can see slight trembling movements in the deep finger flexors here, which are fibrillations. So if there's a lot of them, you can see them if the limb is sufficiently warm. And then, well, this obviates the need to stick a needle in that muscle at least. But then I wouldn't replace it, because if there's a few fasciculations in that muscle, they don't displace the muscle enough to be picked up. So, but you can see them. But MRI can also help you. So this is 4 days after a trauma. I'm not sure what happened here, but you can see this denervation edema in the very deep posterior lower leg compartment, which can be helpful. And also if patients refuse to undergo needle EMG, then this can help you find denervated muscles and then extract a clinical pattern.
May I ask you another question about the use of ultrasound to augment your neurophysiology? Have you used it to look for the arrival of the first nascent units within the muscle?
No, we have not. So you might want to see that first unit move, you mean?
Yes, it seems that recently we've sort of fortuitously come across that while just looking for needle placements. And there it is, we can see it wiggling right there, and then we reposition the needle and find that nascent unit that we might have missed otherwise, which is really nice.
Yep. Yeah, I'm sure you could use it like that. What we do see, for example, is something that most people would casually think are fasciculations, but they are actually large contracting motor units at a very low contraction state, an anti-gravity movement.
Okay.
It's called contraction pseudotremor, but the difference with the fasciculation is that they stay in the same place because it's the same motor unit. And then you might not want to confuse those two, but usually these motor units are so large that you can see them from the outside as well. So yes, you could definitely do that. There's even an MRI technique now that can show fasciculations, like a flow void or an image void during acquisition.
Interesting.
Yeah, it is. So another case example of how you could combine these. This is a video again. Poor guy who had a facial nerve injury, or one of the small branches there, with a high impact trauma to his cheek. And then he got these weird cramping contractions that he couldn't control. So this is the injury and the drooping corner of the mouth. And then we're going to look at this muscle here, zygomaticus major, which is, it's small, but you can see it. This is an image of the left and the right of this patient, where you can see them on the left being normal, and on the right, they're hyperechogenic and smaller, so atrophic. And then this is a transverse ultrasound video. We're going from the corner of the mouth with the muscle there, very white and hyperechogenic. Here's the scar region. And then we're going to go back up to the zygoma. I admit it's all very stripy, etc., but you can see the outline of the muscle here still lying on the zygoma. And this was just a preparation to make this longitudinal image that we're now going to see, where you can see the scar area and the hyperechogenic muscle lying underneath, like a string there. And if we turn the video on, then you're going to see the contractions. So these were involuntary and they were bothering this person. And then the next thing we're going to do is stick a needle in under direct ultrasound guidance. I hope you can hear the sound. So yeah. These are sort of myochymic units. So it's a nerve lesion with partial reinnervation. We're going to hear some activation with nascent motor units here. And then these myochymia units in it. Just as I think it's really nice to have this toolkit with several tools in it if you want to assess a patient, and you can just take out and combine whatever you need. It's like building a house. You don't want only a hammer to do that, right? You need a saw and pliers, etc. So that's what this combination of techniques gives us. And this patient was treated with botulinum toxin under ultrasound guidance to stop this. It obviously won't solve his paresis, so we're looking at a cedar jump or another procedure to take care of that. So then, as an overall recap, how can ultrasound and EDx help your treatment of PNS injury? Well, you can localize the lesion exactly, and then I think imaging methods are most helpful for that. You can also assess impairments around the nerve. So if you want to know if the nerve's been hampered by scarring or osteosynthetic material, or we call those cases, please don't screw it, but they do sometimes. You need an imaging technique. If you want to assess lesion severity, obviously you need clinical assessment, but then both techniques can help you for that. And reinnervation, for example, if you have a patient who's really scared or in pain and can't activate the muscle voluntarily, then EDx may be very helpful. And in the later stages, when you want to assess other nerves and muscles as potential donors for grafting or transfer, EDx, the combination of ultrasound and EDx can really specifically target those muscles and ask whether they are suited for such a procedure. So to get back to our universe, I think this would be what I'd like you to take to work, not home, please, but work. That it's actually the best of both worlds to have that toolkit and have both techniques in it. And then take out whatever you need to get that patient the most useful information at that point in time. So with that message, I'd like to say goodbye from our PNS team over at Radboud University Medical Center. And if you're interested in nerve imaging, then we have this digital conference coming up in September. And I'd like to invite you all to just join and see if there's something in there for you.
Absolutely.
Thank you very much.
Thank you very much. A couple of additional questions for you. One of the benefits of MRI over ultrasound for the surgeon is that I can go back and I can put it in context and I can see exactly where that injury is. I do agree that the ultrasound often gives better information, but do you have a way of helping the person who was not present for the study know exactly where that picture relates anatomically?
Yeah, so this is a question that I discuss a lot with our PNS surgeon, the guy you saw, because he always says that it's really hard to translate the ultrasound info into an anatomical context if he needs to go in, and I can totally relate to that. So what I can do though is try and help him by annotating and making a description that is sort of anatomically, is an anatomical guideline, so to speak, to walk through a limb. So we describe saying we scan this nerve in this trajectory from that anatomical point to there, and then at, I don't know, 10 centimeters proximal to an epicondyle, an intercondylar line, you name an anatomical structure that you can find on the outside. We saw a segment so long, so this large, this is the depth, and that's where you need to go. Yeah. And then with that info, usually the patient gets an MRI subsequently for pre-surgical planning. And I think that's, again, using both techniques in an optimal fashion.
Yeah, that makes sense. Or maybe even a photograph of the skin with a marking on it. This is where I was.
Yeah, we do that too. And sometimes we even mark the patient with a not permanent marker, but not a tattoo or anything, but just prior to surgery. And we even do that sometimes to prevent nerve injury. So my colleague, Stuart Wijntjes, who was also on the image there, he works in a large orthopedic hospital as well. And he has this project where he charts the saphenous nerve, for example, prior to knee surgery. So it just puts an X on the spot, in this case, to say, avoid this, please.
Right. No,
that's making sense, I think.
Yes, absolutely. Now, I think you might have a better ultrasound than we do, because some of those pictures are really crisp. Do you think that's...
Yeah, what machine are you using?
What machine are you using?
Well, this is... that's a good point as well, because we have several ultrasound machines, and some are really high-end, but all these high-end machines like Canon or GE machines, they are not really targeted for nerves. So they're good at MSK, but then they tend to make beautiful images and smear all the connective tissue structures together. Well, for nerve imaging, you need something that if you change the angle of scanning, you get big contrast changes. You have to make maximum use of anisotropy, so to speak. So this is a sonocyte machine that the anesthesiologists use a lot in the military. And it makes these very hard, compressed images with a lot of sensitivity to anisotropy, which is really good for finding difficult nerves in blurry textures. If we want to show you a beautiful image of 25 fascicles in the median nerve in the carpal tunnel, I'm going to use the Canon, for example. But for this purpose, it's really nice.
Are you using any intraoperatively?
Yes, well, not intra, but we're in a project with a renal surgeon to prevent subcostal nerve injury. So we scan pre-incision, and then right after, it's a research project to see how much traction on the nerve with the endoscopy instruments. I know of my neurosurgical colleagues who use it for example, for spinal cord tumors, to see if there's any residual tissue with another texture left during the surgery.
Yeah. And do you think it might be able to look at neuromas and see if the fascicles any fascicles are going through that might be spared, or whether they're just all bundled up?
I think this would make sense intraoperatively, because with an intact patient in the just in the clinic, you need to be able to assess it at a very superficial depth to do what you're proposing. But intraoperatively, if you have direct access to that nerve, that surely makes sense. And it's sort of like a handheld microscope, right, during the procedure.
Yeah, we haven't done it yet, but Ross has been convincing me that maybe this would be as useful as the intraoperative nerve action potentials to really get an anatomical view of what's going on inside that neuroma.
Yeah, and I think makes sense. And you even have a portable, wholly portable system. So just a handheld scanner at this point with which you project via Bluetooth or Wi-Fi on an iPad or a screen or whatever.
Yeah.
And you can just wrap that in a sterile foil or whatever you need, and then take it. And there's one supplier who has a high frequency linear probe that we just started playing around with. But that, I think in a couple of years, we'll see more of that. It makes it more easily accessible.
And have you delved into the ultra high frequency nerve ultrasound work?
A little bit. So we have a machine in our ultrasound research group that is a 70 megahertz max. Well, yeah, that's beautiful for very high resolution images. So
is that the Vivo system? Is that the Vivo MD system?
Yeah. It's one of it's a preclinical version of it, so to speak.
Okay.
So we don't have the clinical one, but yeah, that would be excellent for intraoperative microscopic appearances from the outside. What we do now is, for example, scan fingertips to look at an autonomic dysfunction. So contraction of blood-filled spaces, etc., is very impressive, but you can't see more than a centimeter and then the image is gone.
Interesting. Now, our colleagues from San Diego, after we left, delved into that in animal models. And we're noting that you could measure off the fascicular area within that sciatic nerve, and it would correspond to the number of axons that were traversing that region. We thought that was pretty exciting, and would love to translate that into the clinic.
Yeah, that sounds beautiful. So if you have direct access to the nerve, I think that opens up the possibility to do this.
Absolutely.
And then predict recovery, I think even better, right?
Yeah.
Do you do much with, or have you done much with the elastography, or any thoughts on elastography, whether it can be used with muscle or nerve?
Yeah, no, well, my colleague is a technical medicine specialist who specializes in diaphragm and ultrasound of breathing. So he uses elastography to assess the diaphragm function, which is pretty hard given its curved shape, etc. We haven't looked at it clinically for other purposes ourselves because we have a very robust, if quite simple, system of looking at echogenicity and quantifying it. It works fine for us at this moment, but I know of groups who've looked at patients with Duchenne's muscular dystrophy, etc. And it's a robust measure of the changes in muscle tissue, at least. And I know of some groups that are doing nerve elastography, but I would say it isn't there yet because it's hard to standardize and very dependent on the angle of insonation. And that's a big thing for nerves because they traverse all sorts of directions in your limbs. So that's something that needs a little more work. But in the end, you might want to predict, for example, pressure in a certain compartment using this technique.
Yeah, absolutely.
Yeah, I was going to say, and the last question about muscle is, beyond watching the fasciculations and the movement of the muscle, are there echogenic features of the muscle that give you some insight into the innervation status of that muscle or the health of that muscle?
Yeah, there are. So we know from this, so we scan, we do quantified muscle ultrasound regularly, like 900 times a year or something, just diagnostically to screen patients whether they have a chance of having a neuromuscular disorder or not. And then you have about, I don't know, 85% certainty if the ultrasound is abnormal that they do. What we found out though, when we started delving into those data sets, is that neurogenic disorders give much less ultrasound changes than myopathic ones. So you will never miss a Duchenne, but you will miss someone with an S1 radiculopathy who had collateral reinnervation after a couple months, because it turns out that you need to have persisting denervation without adequate reinnervation to see the muscle changing from normal to hyperechogenic or fibrotic, if you will. But once you see that, it's very informative because then you know a lot of axons have been damaged. And this is how we, for example, screen kids with traumatic nerve injuries, that we just pre-screen the whole limb with muscle ultrasound. And if you find any abnormalities compared to, for example, the contralateral side, just eyeballing, then you know that you need to look further in the territory of that nerve, and we would scan the nerve subsequently. So it's a nice clinical trick.
We're quite interested in that window of opportunity as well, and using the ultrasound because it would be persistently denervated at that point. So it might be more interesting on ultrasound see if it's a biomarker for when you're crossing a threshold for reinnervation. I know you've seen a lot of denervation. I wasn't sure if you looked at it over time and seen a window or a biomarker correlation there.
We haven't looked at these in a systematic or longitudinal fashion. No, so that would make a really nice project.
Yeah, absolutely. Speaking of which, who are your surgical colleagues there?
So my main sparring partner is, I'll just skip back this slide, the guy on the lower left there. He's a plastic and hand surgeon.
Okay.
And there is a small team. We have an orthopedic surgeon from our neighboring hospital, Oscar Dorrestein, who works on muscle transfer, etc. It's a restorative surgery as well. And of course, we have neurosurgeons in the Netherlands, but in our hospital, the neurosurgeons focus more on CNS tumors, etc., as their attention point. So they give this to the plastic surgery, so to speak.
To say, the Netherlands seems to be more interested in peripheral nerve injury than most other countries per capita. There are a number of centers there where people really have a lot of expertise in peripheral nerve.
Yeah, so sure. You have Leiden University Medical Center with Martijn Malessi and Willem Pondag, who are, I think, in neurosurgery. If anyone has a brachial plexopathy in our country, they would go there.
Okay.
And it's also the type of surgery that we are a small country, right? It's just 70 million people. So if you have this type of lesion and it's rare, you want a team that does this more often.
Yeah.
So we are able to, we have a different healthcare system as well. So we are able to sort of make agreements between us that we're not going to mess around in a proximal brachial plexus, but anything distal from the foramen, we would just solve ourselves. And I think between Leiden and Nijmegen, I think we're basically the only centers that do this comprehensive approach.
For the iSpiny meeting, I've been meaning to come for years, or trying to, but is that just virtual, or is it in person as well this year?
Unfortunately, the main part of the program, so there's a course 1 day and there's a conference 2 days. And then that's all digital because of the travel restrictions that still apply to a lot of people across the world. But we did organize there's a live session, a 1 hour session where an expert from, I think, Brazil, Rome, and Singapore are gonna scan whatever you want. So you can just log in, you can yell median nerve at them and they're gonna live scan it for you.
Great. Yeah,
that's great.
We've got a conference coming up here fairly soon where we've got some cadavers in there. So we're gonna try and get the surgeons to show us what we've actually misinterpreted on ultrasound.
Oh, right.
We were hoping restrictions would have let up so we could have invited you out, but maybe next year.
I'd be delighted to. And yeah, next year's better because I'm still not sort of stuck here, I guess.
Yeah, and that's common. Lots of people canceled last minute for that. Well, thank you very much for sharing with us this morning. That was excellent. Really enjoyed it.
Thank you.
Thanks very much.
And thanks again for the invitation and have a good working day.
Thanks so much. You too. Bye-bye.
Bye-bye.
How do I stop? Is it stopped?